Okay, hello again. On this particular DVD, what we are going to talk about is what I will call AB, like the letter A and the letter B, or baseline design. You will read some about this in texts or journals, and if you do a more sophisticated version of what we are covering the basic preliminaries of in here, it falls under the title of single subject design. Single subject design is the term for what is seen as the most rigorous form of research that you can do when you have an N or a sample size of 1. And if any of you go on and really want to do research, if you want to do a workshop, if you want to do a lecture series or become rich and famous, or at least famous, for presenting evidence of how well a particular clinical intervention works with an N of one client, or one client here, one client there, one client in the next place, but you don't gather data together in a large group, this is the most powerful tool that you have to use. So single subject design can be very sophisticated, it can be very rigorous, and it even, yes, can be mathematical, and you can use statistics on it. We are not going to begin to get to that level of sophistication. This is sort of the basics, the starting blocks of a baseline design, the A and the B. The A stands for the sort of baseline or pre-intervention phase, and the B stands for introducing an intervention. I will talk some about ABA, which is no intervention, introducing an intervention, and then removing the intervention and going back to without intervention in place. And the scientific basis of that, we'll also talk about the ethics of that, and we'll also talk about the conceptual problem in social work and doing counseling with clients and the problem of an ABA design conceptually in our field. But know that the reason for single subject design, it is done well, and with an AB, at least A, it is the most rigorous form of data collection that we have to demonstrate that my intervention led to my outcome. So if you go back to the DVD where we talked about those fascinating threats to internal validity and causality, the purpose in doing this kind of work is it's the strongest evidence that we have to say it was my intervention that led to the outcome and not something else. And if you remember from that lecture, there are all those threats to internal validity. We had history and maturation and selection bias and test sensitivity and regression to the mean. Oh no, we didn't go over regression to the mean. And experimental mortality and a whole host of other things that could lead to, there are those plausible alternatives in terms of causality, other things that could have led our client to change outside of treatment. The reason to do a rigorous single subject design is that it does the best of anything we can with single subjects. Because remember, control group. Well, single subject doesn't have control group, it's single subject. So it's the best method we have to say it really was the treatment that led to change instead of it being something else. So with sort of that premise and appreciating that this is for the purpose of causality as best as possible, what are the components that go into place in terms of doing an AB or a baseline design? So first of all, we have the question of what is a baseline? A lot of people use the term, I need to get a baseline. And in the DVD that I recorded for talking about doing self-monitoring, I talked about how self-monitoring can be helpful to, quote, get a baseline, unquote. So what do we mean by get a baseline? Well, generally speaking, when people toss that term around, they mean get a measure of where the client is at before they start an intervention, which for this class, the most common intervention is treatment, whatever that may be. 50 students are doing 50 different interventions. But Baseline is what the client's behavior of interest looks like before we do some sort of intervention or treatment for it. So let's say, for example, that you have a mom who comes in who is absolutely at her wit's end because her child just is throwing tantrums. Her 3-year-old is throwing tantrums right and left, and it is driving mom absolutely bananas. You could say, well, I'm curious as to how many tantrums your child has. So it would be good if we could get a baseline. Now, many times people think that's like, okay, well, how many tantrums did my daughter have today? And you could get a baseline of today. Very often people come into treatment and we give them an anxiety test, or we give them a parenting test, or we give them a stress test, or we give them a self-esteem test. And lo and behold, their depression or their stress score is way up here in the stratosphere. And then we work with them for a month or 6 months or a year, or however long we work with them. And before they're ready to go, we give them the same distress test of whatever nature. And their score is down here. And we say, hey, way cool. The client started treatment and their distress level was up in the stratosphere, and now it's down in the normal range. Treatment has helped. And sometimes that's true. But if our baseline is one point in time, if you think about what leads people to come to treatment, it's very often not solely that I've had this problem, it's been going on for a while, and I just happened at random chance to pick up the phone and call and come into your mental health center. It's often I had this problem, it's been going on for a long time, my kid has been driving me crazy, my spouse has been driving me crazy, I've been feeling terribly depressed, whatever is the problem, and then a crisis hit. The proverbial SHIT hit the fan, and now I'm a wreck. And I come in, and when I come in, I'm highly agitated, which drives scores up. Well, if I only get one moment in time, that moment in time may be very, very non-representative of how I usually feel. And the score that we get credit for, we take credit for as post, really may, if it's just one other moment in time, it may be very unstable too, but this may be where the person's sort of basic level of functioning is, but because they came in on a crisis, that score was very elevated. So if the mom calls us with this tantruming child, she's gone nuts. And you say, well, how many minutes per day does your kid usually tantrum? Today she's tantrumed for 3 hours and she hasn't shut up. Okay, 60 minutes, that's 180 minutes. Okay, so if we put this as 180 minutes today, and on a typical day this kid only tantrums for an hour, it's going to plummet with no treatment. So we want to get a baseline. Baseline is, how does it look over time? And with one person, when we have multiple people, if I want to get a sense, I want to do an intervention to reduce stress among graduate students. And so I do cognitive behavioral relaxation exercises intervention. And I have a class of 25 students, and I give them all some sort of stress test. If I have 25 students, there are going to be some students in the room who have had a horrifically bad day or week, and their stress levels are peaking. There's going to be a couple students probably in that class who've had a lovely, blissfully easy week, and their stress levels are way lower than typical. And then there's going to be most people whose stress level is about where it usually is, except for if it's finals week or something like that. So if we have multiple people, we have the people who've had highly stressful days are balanced out by the people with very calming, soothing days, and then most of the people in the middle. And it sort of all comes out in the wash, or all averages out, as we say. But if I have only one person, with one person in one day, that may be a very freaky, fluky, unrepresentative day. So with one person, in order to get a picture of what it looks like, I don't have 24 other people to average out the class level of stress. I only have one person, so I have to get multiple days. So if this mom is gathering how many minutes her kid tantrums, you want not just today when she's calling the mental health center in a crisis, but you want mom to gather some data on her kid. So let's say she's calling you, it's a Tuesday, your next appointment is Wednesday. You could say, could you keep track of how many either tantrums your kid throws each day, how many minutes your kid tantrums each day, and just chart it, right in a little place on the refrigerator, right in your daily planner, right wherever mom can find to write. how many minutes each day your daughter tantrums, and then when you come in, we'll kind of have a picture of what it looks like, and that'll help us know if our intervention is working or if it's not. If people are charting their mood level, chart your mood from now until next week when we have your appointment. And then we'll get a sense of, is your mood usually, if it's a stress level, is it usually up at a 10 out of 10? Is it usually at a 1 out of 10? Is it terribly fluctuating and variable all over the place? But you want to get this baseline, which is multiple points in time, to get a sense of what is typical. What does this usually look like? Is it usually very fluctuating and random and unpredictable? Or do you have a couple really bad days, a couple really good days? But generally speaking, this is what your level of whatever it is that you're interested in looks like. So that's a baseline. How many data points do you need before you can call it a baseline? Well, you want to try to see a pattern. How much do you need before you see a pattern? Well, there really isn't an answer. Sometimes there is no pattern. But a general sort of thumbnail idea is most people will say, get at least a week's worth of information. If you can get more information, cool. So how do you get a baseline? Well, oftentimes if you actually talk with somebody on the telephone, let's say that you manage to get the phone calls in your agency, you talk with the client or you get a name of someone and then you call them to set an appointment. A great way to get information is on the telephone you talk with them about their concern, and then you see, could they gather some information for you between the telephone contact and their first session? And if that can work, it's very cool for several reasons. Number one, you get information right from the get-go when the person walks in your office that you can start working on. Number two, the client feels like they're doing something. If this is the mom of the tantruming child, she doesn't feel like she's got to sit here and wait until next Wednesday and that's 8 days away and she's going to go nuts. She's doing something. She's proving to you how crazy her daughter is driving her. And she's got evidence, and it makes her feel like she's doing something to promote treatment, and she's able to gather evidence to convince you that this really is a problem. If someone is writing down their stress level, again, they're working towards solving the problem. They're working towards giving you information about their life. So if you can talk to people on the phone, it's very cool. Many of you don't get that opportunity at your agencies, so then if you meet with someone at the first session, have them gather it between the first session, the second session, and so forth. And often the first session is just assessment before you really start treatment planning. So it kind of counts as a pre-treatment baseline. So, and you want to get usually at least one data point per day over the course of at least a week's time. Now, some things are hard to get information on a daily basis. Let's say it's, number of arguments you have with your partner. Well, it might be that you and your partner argue multiple times a week, but not necessarily multiple times a day. If you have a child who's anuretic, wets the bed at night. Again, it may not be multiple times a night, but it's multiple nights a week. So sometimes the data you gather is weekly rather than daily, and then it's hard enough to get a lot of information and postpone treatment for 5 weeks so that I have 5 data points on how much my kid wets the bed. Well, the client is calling because they want treatment for their kid's enuresis now, not 6 weeks down the pike when you've been able to gather information for 5 or 6 intervals. So sometimes it's hard to gather information which really has to be compiled weekly rather than compiled daily, and there's not necessarily a good answer to that, except for sometimes you can treat problem A while gathering data on problem B, and then once you've got enough data gathered, then you can start treating problem B. And sometimes that just doesn't work for ethical and clinical reasons, and then you just don't do this. Another thing when you're doing a baseline is that you want to have data which is countable. That is one of the kind of restrictions of doing this kind of data, is it has to be something which you can turn into a number. So number of minutes that a child tantrums a day, number of arguments that you've had, stress level on a 0 to 10 or 0 to 100 scale. You can't really do mood, mood as in I feel grumpy, mood as in I feel elated, mood as in I feel bored, mood as in I feel angry, because it's different kinds of things instead of different levels of things. Countable needs to be variable levels of the same sort of thing. So if someone wants to chart their mood, what might be helpful is to say, what are the moods that give you the most trouble? And if someone says, well, I get really sad and I get really angry. Well, you could have them chart sadness and you could have them chart anger separately. And then they could put a sadness level that could range from, 0 to 10. 0 is either no sadness, 10 is exceedingly sad, or 0 is very happy, 10 is very sad. With anger, 0 is very calm, 10 is very angry. But you can't have them put like angry, sad, fearful, grumpy, and so forth, because it's different qualities instead of different quantities. And this has to be countable. It has to be different levels of the same thing. So you can look at multiple things, but each thing has to have quantity in it. So you can chart sadness, and you can chart grumpiness, and you can chart anger. But that's 3 separate baselines. It's not, you can't like hodgepodge them all. Or you could put 3 separate, like pink line, a blue line, and a green line or something like that. But you have to chart level within each of those. So I've written here just some examples of different things that you might want to chart. Stress level, number of arguments, number of tantrums. Again, you could do number of tantrums. You could also do sort of duration or minutes. So I lived with a woman one year when I was doing my internship who had a 6 and 7-year-old daughter, 6 at the beginning, 7 at the end. And her daughter could easily tantrum for 45 minutes or more, just go around the house and scream nonstop, which amazed me, who I wasn't a mother at the time. And so you might want to do duration as well as number, or duration instead of number. Latency to sleep. If you have clients who have problems with insomnia, latency to sleep, what that means is how long it takes from when you lie down in bed until you fall asleep. Sometimes that's hard because you don't know exactly when it is that you fall asleep. But some people do know that, I went to bed at 11 o'clock and I was still staring at the clock, and it was 2, and it was 3, and it was 3:30, and then I lost track. So at least 4.5 hours you were lying there in bed staring at the clock. So latency to sleep, how long it takes from when you put your head on the pillow until you actually fall asleep. If people have diabetes and they're taking their blood sugar level, oftentimes blood sugar gets out of control as a result of lifestyle. So many times social workers will work with people with diabetes to help them moderate things like their food consumption, their exercise, their stress level, lifestyle factors, which really influence blood sugar. And if blood sugar gets out of whack, it also influences one's mood and one's ability to cope well with life. So there's a huge psychosocial component as well as physiological component here. You can track things that you consume, such as number of cigarettes that a client would smoke, number of cups of coffee they consume, the number of candy bars a day that they eat, or chips that they eat, or whatever. If you can quantify it, then you can put it down in terms of some sort of baseline scale. And what the chart looks like, and in a few minutes I will put a more attractive filled out chart up on the board, but what the chart tends to look like is you make a graph and you put time or some indicator of time down on the horizontal or the x-axis. And up the top here goes whatever it is that you're counting, which is either your frequency, that would be how often something is happening, or your duration, which would be how long something is happening, or your score or something, which would be my score or level, which would be, my level of stress on a 0 to 10, my level of depression on a 0 to 10 scale or something like that. So that up this side goes whatever it is you're quantifying. Out this side goes time, and you can either put this, day 1, day 2, day 3, week 1, week 2, Monday, Tuesday, Wednesday, however you want out there. And then somewhere in here, you put a line, and the line is your intervention. And the intervention is, again, there's an A-B design. The A is the pre-intervention phase. So this is when the client is gathering information, but they haven't started doing something actively to change it. So the phone call has been made, mom's told you that her daughter's driving her nuts, she has tantrums for hours and hours on end, and you say, how about if you just let me, if you count how many minutes or hours a day it is, how about if you count how many minutes a day it is, and chart it each day this week, and when you come in next week, we can take a look. And it'll give me empathy and understanding of what's going on, and it'll also help us to treatment plan better, and it'll also help us to know if our intervention's working. The B phase is, this is the intervention starts, and the B phase is during the intervention. So now mom brings her daughter in, and you do some cognitive behavioral therapy with the mom, maybe you do some play therapy with the daughter. Whatever the intervention is, you're working with them and you're gathering continuing information of the duration of the daughter's tantrums. And so let's just say that hypothetically, the behavior of tantruming sort of looks like this. And then we go to the B phase, and little by little, the daughter's tantruming slowly starts to fall off. That is the most basic form of the A-B design, where you've got a pre-intervention phase and you've got an intervention phase. And you have multiple points in time so that you have at least some evidence that it's not simply a fluke, that today when my daughter was driving me nuts, I called, and her behavior is usually here. Let's say mom is just freaking out, and so she calls and the daughter is here. But generally speaking, this kid's behavior is not up here. This was a really bad day. She got back from visiting Bio Dad's house, and Bio Dad is just horrible, and the daughter is all just freaking out. And so what the kid's behavior actually looks like is usually sort of like this. And if we do treatment, it still kind of looks like this. It's just sort of all over the map. But this isn't so unusual. But if it looks more like the blue line, then the kid's behavior really is maybe more troublesome. But if you only have one point in time, you don't know if that point is the whole high point or if that point really is very much more typical. And if you have a good day in treatment, treatment if you measure it here looks very effective. Treatment if you measure it here doesn't look so effective. This day here is actually worse than this day here, whereas this day here is way better. So it depends on the point in time if it's just 2 points. So you've got your baseline, multiple points in time. You've got your intervention. You've got multiple points in time after your intervention. The first 2 building blocks of your A-B design. Now, if we want to show that it really was our intervention that led to the outcome and not something else, those rule out plausible alternatives, those threats to internal validity, one of the things that works fairly well in a medical model, at least sometimes, is what people will do is they will pull the intervention. The theory being that if something is working, if I take it away, if it was that something that's working and I take it away, the behavior should go right back to where it was. And some things fit this model really well. Think about insulin-dependent diabetes. If I have a client with insulin-dependent diabetes and I chart their blood sugar prior to giving them insulin, their blood sugar probably looks like this. It's all over the map, and it tends to be pretty high. Now, I give them a drug. Let's say this is back in the dark ages before we sort of knew that insulin was what we want to do, and we're just testing this new thing called insulin out. We give people insulin And so this is now our intervention. And what happens to their blood sugar is this. But let's say, so it drops, it's a little more steady, it's less chaotic, and it's a little more steady. So let's say we say, well, you know, it certainly looks like as soon as the person started taking insulin, their blood sugar level started coming down. While it's still not absolutely steady as a rock, it's a lot more steady than it is here. The peaks and valleys are about this far apart. These peaks and valleys are that far apart. But how do we know it was the insulin? We're back to rule out plausible alternatives. We have our, if we talk about causality, we have our temporal order. We have the insulin happened first, intervention happened first, then blood sugar levels came into more control. So we have our order. If we have correlation, correlation is if multiple people over the years or over the days or weeks or whatever started taking insulin, and over the course of many people, insulin led to a drop and a stabilization of blood sugar. We have a correlation. When people take insulin, when people with diabetes take insulin, their blood sugar level tends to get more stable and lower. Rule out plausible alternatives. Well, let's say that with our client here, at the same time as the blood sugar level dropped, they started graduate school. We now have a competing hypothesis. Is it that you started taking insulin, or is it that you started a master's program in social work that led to your blood sugar dropping? Well, I don't know. It's a confounding variable. It's sort of one of those history threats to internal validity. It's outside the person, it's outside of the study. Was it the starting graduate school? Was it the insulin? Well, nowadays we say, duh, it's the insulin. Everyone knows graduate school, if it does anything to your blood sugar level, it probably shoots it up because it shoots up your stress. But let's say we don't know this. Let's say this is a new experimental drug. We're always trying out new experimental drugs. There's drug trials going on all around the country all the time. Is it the insulin? Well, what's a logical thing to do? We don't know if it's the insulin. So, if this is our A phase, this is our B phase, what we do scientifically is we go back, we remove our intervention. And when we remove our intervention, we call it going back to the A phase, which is really, conceptually got some troubles to it. And we'll get there in a minute. But if we pull the intervention, and it was that the intervention was working, if the intervention is insulin, what do we expect will happen? Well, as a matter of fact, if we pull the insulin out of the person's bloodstream, what we expect is that it's going to start looking, their blood sugar is going to start looking like this, just like it was in the A phase. This is called sort of the return to, or A phase again. We draw our line. This is our time on out here. So we've got pre-intervention, blood sugar out of control. Intervention, blood sugar comes down, lower and in better control. We remove the intervention, blood sugar gets chaotic again. Person's still in graduate school. We've now ruled out graduate school as the causal agent, but boy, it really looks like there's a strong hypothesis when insulin was in, blood sugar was in control. Insulin out, blood sugar crazy. Let's try it again. We go back to another intervention. A, B, A, oops, intervention, A, B. If it really is the intervention that is leading to the outcome, what we expect to find here is as soon as our client starts taking the insulin again, we expect the blood sugar to again come back down and be more predictable and lower. And again, if we pulled, if we did A, B, A, B, A, B, A, B, A, B, all the way out the window here, we would expect that every time the insulin is present, blood sugar is going to be under better control, insulin is pulled, if it really is the insulin that is causal. So an ABA design is I get a baseline over multiple days, then I introduce an intervention, and I see if there's a change. But in order to really have good evidence that it really was that intervention and not some other just coinciding event, some threat to internal validity, some rule out plausible alternative kind of deal, some confound, You pull the intervention, and if the change goes away and it goes back to the A phase, then we say that is some really good evidence that it really was the intervention, it really was the insulin. And you know, that works very well when we talk about things like insulin. It really doesn't work so well when we talk about a lot of what we do in social work. Because what we do in social work, we like to think of, at least in many cases, as not akin to insulin, but more akin to amoxicillin. If I have strep throat and I measure my temperature, high fever with strep throat, I take amoxicillin, fever comes down. I stop taking amoxicillin. Does my fever go back up? If the amoxicillin worked, no. My fever does not go back up. My fever stays down. Why? Because the amoxicillin killed the bacteria that was causing the infection, which was leading to the fever. If we take away the bacteria, we take away the infection, we don't need to have a fever anymore, it stays. It looks then like when we go A, high fever, B, intervention amoxicillin, B, low fever, then we go back to A, the fever doesn't come back. Well, the amoxicillin didn't work. Well, actually, our conclusion is exactly the opposite. No, the amoxicillin did work, and that's why my fever didn't come back. Well, social work, very often, we hope is amoxicillin and not insulin. We hope that we go in and we work with our clients and we teach them new life skills. And because they learn new life skills, they are different people. So you teach mom new ways to handle her daughter's temper tantrums, and when you stop working with mom, you hope that mom continues to maintain those same new skills that she learned, and her daughter, if the daughter was in play therapy, the daughter has maybe gotten over some issues or problems or concerns or something, that there's been a change in this family unit, and that the daughter now, she and mom can get along without needing all the tantruming behavior. So ABA works really nicely in theory when it's things like insulin models. And there are some things we may do in social work which are like insulin. I personally believe that if we work with people with borderline personality, oftentimes our intervention really may be more maintenance. It helps people with serious borderline, maybe not drink and drug so much, not get into crazy relationships, hold a more stable job, not self-mutilate, not have suicide attempts, stay out of psych hospitals. But sometimes it's almost like they need that continuing, ongoing support. And if we pull it, it's like pulling insulin from someone who's diabetic. Only unfortunately the medical community considers pulling insulin to be malpractice, and they do not consider pulling therapy to be malpractice. And that's a political issue, not a measurement issue, but it is definitely a political concern. People with schizophrenia. We do not assume that if we give people with schizophrenia antipsychotic meds, or we do really good social skills training, or we do really good case management or counseling, that the schizophrenia is going to go away. But we do appreciate that people with schizophrenia, many of them really do benefit from having some kind of ongoing contact with case manager, with counselor, with skills trainer, with staff in a group home. That's just ongoing contact to help them maintain as stable and meaningful a life as is possible. And if we pull that, it's like pulling the insulin. So there are some things we do in social work which really need the treatment to be ongoing, and if we pull it, we really do see sort of this return to the old sort of problem concern areas. Others, we really hope that with education, with support, with working with our clients, they really do change, and the change really sticks. In cognitive behavioral therapy, you hope people learn new skills and behaviors. You hope that people learn new ways of looking at things. In reality therapy, you hope people sort of change their shift on how to perceive life and develop some new tools and skills and form healthier relationships and better ways to meet their needs. It's a change we hope is stable. Return to the A phase, behavior should hopefully hold where it was in the B phase. So AB works well sometimes, but you have to think about the theory and the conceptualization of what it is you're doing. Another sort of problem with AB is sometimes just, and I talked earlier about how do you gain information on something without intervening. Sometimes you can do it after the phone call. some behaviors you really have to intervene on right away. If you have someone who's self-mutilating, if you have someone with suicide attempts, you can't say, well, why don't you just chart all of your suicide attempts and how many you make every day, and then we'll see if it changes after we work together. Someone comes in suicidal, you got to get on it right then, right away, to A, keep them alive, to work on things, and B, because ethically it's catastrophic if you don't pay attention to something like suicidal behavior. So sometimes there's ethical problems to getting a baseline. Sometimes there's ethical problems to pulling an intervention. I worked with we had a student a number of years ago who was a good student and really wanted to do her AB design really well. And she worked with a mom with a kid on enuresis. And she had taken the solution-focused therapy class and had learned a wonderful solution-focused intervention for helping with enuresis. And she taught it to mom, and mom put it in place. And it was something a parent, I think, needed to pretty actively do. It was an insulin. It wasn't an amoxicillin. And so the mom did it very actively with the kid, and the kid's dry nights went from about 2 or 3 dry nights a week to pretty much 7 dry nights a week. So the kid really did great. And then the student suggested to mom, well, how about if we see, now we're supposed to do this return to A phase. And so the mom dropped the intervention out. Kid started wetting the bed again. So it sort of broke my heart as a teacher to read the report on this, because while it was nice evidence that it was very important that the mom keep doing the intervention that the mom was doing, because it really did work, it was when she was doing it that the bed was dry, it sort of broke my heart that the student had erred on the side of science rather than erred on the side of clinical well-being, that you got a kid who can finally keep the bed dry, and the self-esteem wallop that it takes when you start peeing the bed again is just more hurtful than the scientific knowledge gained, in my opinion. So that I encourage the student, please tell mom to put the intervention back in place, have your kid keep the bed dry, and keep it until, it's been a month or 2 out, and then maybe mom could slowly move back and see if the kid was accustomed enough to sleeping dry through the night that she could stick with that. But that was sort of an ethical problem of introducing an intervention and then pulling the intervention. Great science, not so great clinical work. So if you do an AB for this class or anywhere in the future, unless you're doing it sort of for research or scientific purposes, my encouragement to you is do AB, but if it looks like pulling the intervention is not clinically wise, do not pull the clinical intervention. Keep the clinical intervention in place. Now, if you're hired on a research grant and people have signed consent forms and they know this is what's going to happen, that's quite different. But if they're there for clinical treatment, do what is clinically best, and you don't get the return to A phase, and such is life. So, but do good clinical work and simply measure your good clinical work. And you give up a little bit of the science basis, but it's best for your clients, and that's what we're here to do. And I think that is pretty much all I have to say about this, which is the 6th DVD in this series, and that is AB Design.